Welcome back to another edition of the Hart2Heart Podcast. And my guest today is Dr. Abood Bakri. He's an internal medicine specialist based out of California. So Abood, welcome to the show, brother.
Hey, good to be here. Good to be on, Mike.
Yeah, man. I've been following you for a while on Twitter. I love your tweets. You put out, lots of good stuff about, I would say more like advanced or optimization kind of medicine, whatever people are calling it these days, biohacking, that kind of thing. But you also put out a lot of funny tweets as well, which I really enjoy. And so we'll probably get into all that today. So super happy to chat with you here.
Excited to be here.
So just before we get started though, just maybe give the audience a little bit of a brief background about yourself and sort of like your overall thoughts on medicine and where it's going.
Yeah, I'm a internal medicine attending physician now, finished residency last year. So I've been in practice now for a year independently. My practice varies from, inpatient, ICU, floors, all that kind of stuff, admitting patients. And then on the other side, like you mentioned, more health optimization and health promotion. Kind of cool to see, all the ends of the spectrum. You see somebody who wants to prevent a heart attack in their 30s and somebody who is having their CABG surgery, complete bypass surgery in their 60s. So you kind of see the whole spectrum of the medical field. As you're probably well attuned to, is, the last 4 years has been a big fork in medicine, thanks to the pandemic, thanks to all the regulatory agencies. And people are really seeking out, health optimization, something more than the traditional, just come in, your doctor listens to your heart, he checks your lipids, and then tells you, okay, you're good, see you next year. People, I think, are seeking a little bit more, thanks to people like Dr. Tia, Dr. Huberman. All these people are promoting this health optimization, health performance, all these things. And I think that's where medicine becomes interesting because we can really help people take their game to the next level.
Yeah, and I wanted to mention something too that you chatted about on Twitter before, because I'm the same as you. Like, I love reading about all this stuff, but most of the stuff that I actually practice in clinical practice is mostly acute stuff,
right?
And I do enjoy acute medicine for whatever reason. I don't know if it's the rush or whatever it is, but I sort of do like, acute medicine. But I remember one time, you had mentioned that maybe it's time for us to almost split up like primary care. You go to, a certain family physician if you're having, an acute infection like a cellulitis or a strep throat or whatever it is. But if you're looking to say like optimize your hormones or looking for, blood work that maybe, a lot of doctors don't order or maybe are not that familiar with, you should go to, a different kind of physician. And so how do you see that happening? And do you think that there's a space and a movement for that?
Yeah, I mean, so I did my training at Loma Linda, which is, one of those blue zones. For whatever that's worth, I know there's a lot of controversy around that, but they had a lot of lifestyle medicine / lifestyle performance medicine subspecialists that existed there, and they would, check different labs that people aren't trained on, and try to help the person, whether that's sexual optimization, physical optimization, as far as the physique, mental optimization, and these kind of things, and that's what really sparked my interest in this. But what I realized is there's just so much that the family medicine practitioner has to learn, or the internist, whoever is seeing the patient in clinic, that it's almost impossible to do both and do them well. The guidelines are always changing. There's so much that needs to be studied, learned, relearned throughout your career, so that it's almost impossible to have one person that can do the full gambit of everything. So you almost have to either be maniacal and do 80 hours a week of learning, you can just keep up, or you're going to have a new specialty, which is like wellness, and I hate the word holistic, but some kind of holistic type of specialty that comes out. It's still rigorous. It's still through the traditional training systems, but it's more geared towards keeping people out of the hospital, out of the acute setting that we enjoy.
Yeah, I agree. And I think I've never really heard anyone else, besides you actually kind of bring up that kind of model or bring up, that this way to practice medicine. But I think that, it would be really helpful for a lot of people, because people are looking for something, like you said, beyond just what their family doctor can offer. They want to get into health optimization, biohacking, whatever you want to call it. They want to really optimize the overall health. And, it's kind of difficult to go to someone who, needs to be an expert in both. And like you said, it's difficult for that. So, maybe in the future we will be able to sort of, separate the primary care into, this is your acute primary care doctor. This is more of your chronic, primary care doctor. But I thought it was really interesting that you said that. And like I said, I hadn't had, anyone else. I haven't heard it on a podcast or anything like that. So it's pretty cool that you came up with that. So one thing I wanted to talk to you about was you've mentioned something recently that I'm not too familiar with in terms of its mechanism of action. So the Ozempic, yes, I know it's a GLP-1 agonist, and I know it can help people lose weight and this kind of thing. But the thing that I want to ask you about was, you said it could potentially be helpful for like reprogramming your brain, and you also made a tweet saying that potentially it could be used for addiction in the future. And so I was just wondering, how does a GLP-1 agonist like Ozempic reprogram your brain? And how could it be used for addiction?
Yeah. To think about that properly, the way I see obesity, and I think a lot of the obesity specialists would echo this, is that obesity is more of a hypothalamic disorder. And what I mean is your hypothalamus every day integrates all the signals that are coming into your life: your food, your sleep, your stress, your light environment, your different little peptides that are produced in your gut. They're coming up to your brain and telling you whether to eat, not to eat, to be full, to be not, to be hungry. And all these things are daily integrated into your brain in a kind of a set point model. So there's a set point every day that's being integrated in your brain, and your brain is either giving you the feed signal or I'm full, I'm fine signal. And this goes into the POMC pathway and the AGRP pathway. There's two kind of gas and brake pathways in the hypothalamus to decide if you're going to be eating or you're going to be fasting. The problem in the modern lifestyle is that this pathway is completely broken. Something about the modern lifestyle, whether it's the standard American diet, the high stress, always moving kind of lifestyle, the poor light environment, the blue light at night, the circadian breakdown, it's causing a breakdown to the central regulation. And that's why people, if you speak to someone who struggles with obesity, they tell you like, hey, I'm trying to diet. But then when they do diet, their brain energy levels go down. They become very lethargic. They then become famished for days after. And then they overeat and end up sometimes overshooting their pre-diet weight. So the way I think about GLP-1s is that they are a gut peptide that's produced naturally after we eat. And there's already some data that suggests that obese people actually produce less of this peptide after eating. So when you are reintroducing this peptide to somebody, you are essentially going up to the brain set point, and this peptide acts along the leptin melanocortin pathway, and it tones down the signal to eat, and it brings up the metabolic signal to increase metabolic rate. Because the problem is anyone can be put on a calorie restricted diet, the Biggest Loser and those kind of shows, but people get their metabolic rate drops afterwards. They become super hungry because all of the signals, the ghrelin, the neuropeptide Y, all these signals kind of flare up. And for the next, who knows, months and years, they're now at a programmed rate to eat more to come back to that body weight, because the body likes homeostasis. So if you've been 300 pounds your whole life, your body's going to try to keep you at 300 pounds and get you back there. These peptides work to kind of turn off that signal for somebody that can now go into a caloric deficit. Most people talk about Ozempic, they're thinking, oh, it makes your appetite go away, which is true. That's happening centrally, or it slows down gut transit, so your food's staying there longer. That's part of it. But you'll find in studies where they put people on the braces and they chain up their mouth, they find juices and stuff to get their calories in. Like the brain is very good at making you get calories if it wants to make you get calories. But what we can do with these compounds and why they're interesting is that somebody who's struggled with obesity their whole life, we can kind of reprogram their brain to not feel hungry all the time.
Okay. So they don't, in this case, there's a couple things in there. So first of all, I think the general sort of feeling or narrative on Ozempic is that it makes you eat less, which you obviously agree with. But the other part that you said there is that it does also increase your metabolism, your metabolic rate. Is that what you said? Or
yeah, more so that when you do go in a caloric deficit, you usually have a quite precipitous drop in metabolic rate as your body tries to do the counter-regulatory mechanisms. It will drop metabolic rate, decrease brain activity, kind of make you lethargic, decrease spontaneous movement. Like if you're a fidgeter and you go on a caloric restriction, your fidgeting will decrease. what happens is it seems that Ozempic is taking away this inhibitory signal to lower all these things. So your metabolism can stay high as you diet. So instead of like crashing down, it seems that these people are still able to keep their metabolic rate. They're still functioning mentally well. They're still able to get to the gym. They're still energetic, especially at the lower doses. I've seen patients that, you put on a half milligram, a milligram of Ozempic a week, and they come in later, they're going to the gym, they're fixing the relationship with food. They're not always thinking about food. They're like, there's this background chatter in the mind of an obese person of always eat. It seems that chatter goes away too. So it's like both ways. I wouldn't say it necessarily makes your metabolic rate skyrocket like a phentermine or some kind of amphetamine that someone would take, but it does take away some of that inhibition that comes on the way down.
So essentially, like, when all these bodybuilders talk about like how they have to diet, like,
Yes.
They say it's incredibly difficult to, maintain muscle mass while dieting. And also too, like once you start dieting, you get down in like, single digit body fat, it's just becomes incredibly difficult because your metabolism slows down. But you're saying that if you use Ozempic, even though you're creating a caloric deficit, you're not going to get as much as your metabolism slowed. Is that correct?
Yes. That's what we're seeing clinically. I think the data is starting to move in that direction. But clinically, if you put two people on the same caloric deficit, in a year's time, the person on the GLP-1 will have more of a robust metabolic rate. Okay.
And then what about for people, like, do you have success with people going on it and then coming off of it? Because, the big thing is like people say like, oh, put them on Ozempic, you got to be on it for life. It's big pharma, yada, 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 and all that kind of stuff. But is there, and I understand what they're saying there to a certain degree, because my understanding, and I've had other people say this to me, that like if they stop it, some of the cravings come back, right? So what is sort of, your approach to using Ozempic, and should you go even in it with like that, if I'm going to take this, I may be on this long term, but I may be on this short term. I just need to see how my body kind of reacts to this, because potentially if I go off of this, I am going to have all these signals come back, which is going to increase hunger. But potentially if I, do it slowly, I can just reset. And, I'm sure during that point, you're going to have to use a little bit of willpower at some point, but you will get back to a point. So how do you sort of, approach someone when they're coming in for Ozempic?
Yeah, I think there's two heuristics there. There's the person that's, 300, 400 pounds, their BMI is over 40, their A1C is over 10. That person, I'm okay with a longer trajectory of Ozempic usage because it is a type 2 diabetic drug. That person is probably going to be on multiple drugs for type 2 diabetes anyways. Right. So it makes sense to use that for a longer term. And it seems that the data on those people is promising as far as morbidity and mortality. Now, the person who's, pre-diabetic or not diabetic, just metabolically, unwell, obese, BMI from 30 to 35, what I like to use these drugs as is more of a training wheel approach. And what I mean is you put them on the drug, you kind of give them that momentum, and a very low dose of the drug, you give them momentum, you get them started on their diet, they get into exercising, they see results. So they see the first 5 to 10 pounds peel off. You kind of then go in, and if you have a very astute clinician, you can start to reverse some of those signals. You start dealing with their circadian rhythm, their light environment, their stress management. You kind of teach them how to reset how they eat and how their relationship with food is. And then you get all these things changed while you have the training wheels on. So eventually you can slowly peel off the training wheels. And of course, there's no evidence-based way to take someone off of Ozempic, as it were. There isn't like some kind of protocol. The studies that have been done, they put them on and they abruptly take them off, and then people regain the weight. Now, theoretically, if you were able to taper that slowly, that'd be better. But what I'm finding is lower dose for longer. And then in that time, you have to be very aggressive in changing their lifestyle habits. If somebody just maxes out Ozempic or Wegovy, whatever drug from the GLP category, and then they keep eating potato chips and they're drinking soda and they're doing all these things, you just crush their appetite to the point they can barely eat any calories. If you take that off, they're just going to go back to eating all that junk food, the same lifestyle habits, and they're just going to regain that weight back to baseline or even more.
Yeah, so it's really, I think, about being aware of it. And I almost kind of compare this a little bit to, antidepressants in some way. And I'm not someone who, certainly, pushes antidepressants upon anyone by any means. But, sometimes when people are in a state where they just can't, initiate any of these like behaviors that we're talking about, just because they're so depressed, sometimes, taking something small for a short period of time can reinitiate that, and then they can come off of it. And so, again, like, I don't think we have like robust evidence for that, like we do for Ozempic, unfortunately, but, just using kind of, logic and theory, it seems like, by doing that, it is something that people, could do. So I think that if you are going to come off of it, try to do it slowly. And then also just be very aware that it's the Ozempic that, got you there to some degree, but it's probably more the social or all the behaviors that you did, the physical behaviors, the circadian rhythm, everything that else that you're talking about. So I think there is, a role for them, just like, you do. But I do think that, the approach should be to at least to, unless the person, like you said, is, 300 or 400 pounds, and that's going to take a while, that the approach should always be to, we'll try this medicine, we'll see how you respond to it. And we are going to hopefully take you off this one day, maybe not, we just have to kind of see how things go.
Right. I mean,
it seems to be.
If somebody can reset their set point on their own without medicine, they're gonna, I call it life transplant. They're gonna transform their whole life over, because the life that you had and the genes that you have added together and created this obese result. So if you can somehow change one of these inputs, we can't change the genes necessarily yet, but you can change the input of the life, and then you can have a different result. Great, we don't need to use the medicine. But if you're telling me you're unable to change these inputs, then that's when these medicines become interesting.
Yeah, I love that approach. I think that's the way that it should be done. I want to talk about some of the things seems to be pretty fresh in your mind. You've been talking about it quite a bit recently on your Twitter, and that's leptin.
Yep.
Leptin seems to kind of almost come and go for whatever reason in social media, in medicine. Like, I even learned about it, in undergraduate school, but it just never really seems to hit the mainstream and kind of stay there. It doesn't seem to be that, a test that people really test for and, change their clinical judgment on, or change, their treatment on. And so in terms of, leptin, when would you test someone's leptin, and, how would you do it? And in terms of interpreting the result, once that result is interpreted, what's your overall approach?
Yeah, leptin has never really gotten mainstream excitement going fully, because there's nothing clinically we can do with a lab test for leptin. That's why rarely I will check someone's leptin level. It's more of a clinical examination that you can tell someone's leptin resistant. We know that if someone's obese, their leptin levels are going to be high. So checking that result doesn't really change clinical management, nor does it allow us to intervene, because there are not yet drugs that target the leptin pathway. Now, there are drugs in the pipeline that are peripheral leptin antagonists that some of the pharma companies are working on. That should be interesting, because they use you another approach to target obesity. But there isn't really good interventions you can do besides that knowing someone is leptin resistant. And you could tell that when someone walks into your clinic. You don't need to check the lab result to know that. It's interesting because leptin is a very circadian timed hormone. And that allows us to now do some interventions for somebody to kind of change the way that works. Because if you're able to reestablish leptin sensitivity, and of course, funnily enough, the best way to get leptin sensitive is to lose that weight that made you leptin resistant in the first place. So it's a chicken and egg type of situation. But unfortunately, we don't have good leptin interventions yet.
Okay. Yeah, something that, again, keeps, popping up, but you kind of explained why it kind of never really sticks to the mainstream, because it's pretty hard to, do anything with a test that, seems to be, somewhat, not useless, but sort of tells you something that you already know. And then essentially there's no like intervention for it anyway.
Right. Besides the lifestyle things that we're talking about anyways. So
yeah,
it wouldn't
exactly.
change that.
Okay. So I want to get into some of the testosterone stuff here in a minute, but just before we get into that, why should men worry if they don't have morning erections?
So the morning erection is actually an interesting physical exam indicator, let's call it, because it kind of puts together multiple systems in one place and tells you all the systems are functioning properly. Your circadian rhythm is well intact because LH is produced in the brain in the later parts of the night, and then it binds in the testicles. The testicles are more sensitive to LH in the 3 a.m. to 5 a.m. time. And that means your LH sensitivity is good, your testosterone production is good. Your circadian rhythm is well calibrated because there's a cascade of let's call it a symphony that happens every night with different hormones going up and down throughout the night. And that morning wood is the crescendo of that symphony. You are having good blood flow. So you're not having, blood flow issues or like kind of a cardiovascular disease indicator. There's some studies that show that men who start having morning wood / knee problems will predate their heart disease with 5 to 10 years. So that's a good indicator that somebody's blood flow is not good, and you should probably get them on a stress test or check a CT coronary on their heart. It also puts together the stress system. If someone's super stressed out, they're not going to have the morning wood. So it kind of gives you all these different indicators. If the morning wood's there, you probably know these systems are working well. If it's not there, then you start to look under the hood and see what's going on. So it's a very nice check engine light, let's call it.
Yeah, no, I think you summarized up that, really, really well. And I had Dr. Kyle Gillette on here a couple of times, not sure if you know him, and he's cool. Pretty big on that as well as an indicator, and how it can be helpful for detecting like vascular health. And he's pretty big on using which I'm going to ask about a little bit later, probably Cialis. He uses that quite a bit for his vascular patients, just even 2.5 milligrams, he says, can give some, pretty good results overall. But one thing you've talked about quite a bit too is the difference between DHT and testosterone. So a lot of people, are aware of testosterone. They're not aware of DHT. And a lot of people too are trying to get DHT lower. All they really know about it is that, DHT is bad because it's associated with baldness. It's supposed to associate it with, prostate enlargement. So I need to get my DHT as low as possible. And so can you explain to people what the difference between testosterone and DHT is, and why people shouldn't want to lower their DHT levels?
Yeah. So DHT is dihydrotestosterone. It's the reduced form of testosterone. Testosterone goes through 5-alpha reduction, which just means that you add on some electrons and protons on testosterone and you get DHT. It is a much more potent androgen in that it binds the androgen receptor much more strongly. The way that testosterone exerts its effects is that there's an androgen receptor in the cytosol. It binds to testosterone and then goes into the nucleus and then activates the genes that are associated with testosterone. The genes in the muscles would be associated with growth and rebuilding. The genes in the penile tissue would be associated with libido. The genes in the testicles would be associated with production of sperm and all the stuff associated with that. Like in the prostate, you'd produce more semen. Now, DHT is uniquely powerful at activating this receptor. People estimate 3 to 5 times more. Sometimes people will say 5 to 10 times more. It's hard to tell exactly how much stronger it is, but it is a much stronger androgen. Now, the controversy over DHT comes in, and if you actually look at the clinical literature, before, let's say, the 60s, 70s, DHT is championed as this amazing androgen. Should we be doing DHT therapy mono? Should we just be giving people replacement as they age DHT? Then you get to 80s, 90s, and you find these this patient population in, I believe it's the Dominican Republic. They have a DHT deficiency. They're missing 5-alpha reductase, the enzyme that converts testosterone into DHT. So it's an interesting clinical situation. They are born and they are assigned female at birth, but once they hit puberty, they express so much testosterone from their internal testicles. So externally, they have a labia-looking structure. It's not necessarily a labia, but it looks like a labia. They have a clitoris-looking structure that's actually not a clitoris. It's actually the glands of the penis. But because they didn't have DHT at birth, they didn't develop fully as a male. So DHT is super important for male development in utero and for puberty. But these people, as soon as they hit puberty, the amount of testosterone surges so high that it overcomes some of the deficiency in DHT, so that their what was called the clitoris becomes sort of a penile structure. Okay. And then they go from female their whole life to male after puberty.
That's crazy.
So it's a very interesting situation. Now, I believe it's Merck, if I'm not mistaken, notices these people, figures out, DHT, we can make a drug that blocks DHT. And they come out with finasteride. And that's when they realize, because this population of people has perfect hairlines. They have no recession in their hairline. Their hairline is perfect throughout their life. They're like, hey, DHT must be the cause of hair loss. Let's make a drug that blocks DHT. So that's where the whole DHT is, evil thing kind of comes in, because also DHT is debatably associated with prostate growth and both benign prostatic hyperplasia and prostate cancer. And that's debatable still. Some people will say it's more of an estrogen issue that causes the prostate growth. It's likely that testosterone and DHT are associated with prostate cancer, more so that if you do have a prostate cancer, they're more of a gas pedal, similar to the breast cancer situation where estrogen kind of is or progesterone are the gas pedal on those diseases. But now, after Merck designs this drug, that's the finasteride, there's a whole debate of whether or not DHT is good and whether it's not, it's even useful after puberty. So there's a whole group of people that say like DHT is kind of a trash hormone. After puberty, you don't need it because you've developed your penile structures, your testicles are developed, you've had male development for the beard, for your hair, everything. So you don't need it after puberty. So there's a whole debate whether or not DHT actually causes hair loss, and that's the mainstream opinion is that DHT is associated with what they call androgenic alopecia, and that's when you're noticing the thinning at the sides of your head and then at the crown of your head. That's male pattern, and then you look at the Norwood scale to see how far along you are on that scale. What we do know clinically is that blocking DHT does help with stopping hair loss. What we don't know is if DHT is actually the root cause of this, or is there something else and DHT is down the pathway, and that's where the debate comes in.
Okay, excellent. So it's sort of like potentially the gas pedal on it, like that your genetics kind of set it up, and lifestyle, environment, and that kind of thing. But if you are someone who is prone to hair loss, if you are losing your hair, and then you add in a bunch of DHT, it probably will accelerate it. But it's not necessarily someone who say has lost all of their hair, and then they say they start taking something that has DHT in it, and it's just going to accelerate it further. That seems to be like overall what happens. Is that more or less correct?
It seems to be that if you're genetically predisposed to hair loss, and we can look into what those genetics actually are, that serum levels of DHT are not associated with more hair loss. It seems to be it's a local reaction where the 5-alpha reductase enzyme that transforms testosterone into DHT. If you take a biopsy of people's scalps that have hair loss, they have more of that enzyme, even though their serum levels of DHT aren't higher. So there's kind of a discordance between serum DHT and then local scalp DHT levels. So that's where the debate comes in. Like some of these people, they're not high testosterone by any means. Like you'll find a patient that has a testosterone of 250, 300, yet they're suffering from really bad male pattern baldness. So is it really the androgens that are the cause, or is it some kind of blood flow, inflammation, poor lifestyle, stress that's loading the gun locally? On top of that, when we talk about genetics, not only do you inherit androgen receptors and all these things from your usually paternal grandfather or maternal grandfather, and there's a debate on which side of the family leads to hair loss more, but you also inherit the shape of the head. And there's more scalp tension in a certain area of your head that could predispose those follicles to get worse blood flow, worse nutrients. So then DHT might be more of a recycling agent there, in that it's getting rid of hair that's not well fed. But it's hard to say exactly. I will say the mainstream narrative, like 95% of people are going to say DHT is evil, get rid of it. But me personally, I think the DHT has such powerful role when it comes to cognitive function, to sexual function, to overall motivation, especially because the 5-alpha reductase enzyme is also associated with neurosteroids like allopregnenolone, 3-alpha-diol, all these different neurosteroids that are associated with like GABAergic qualities and this calmness that comes from androgens. And they're associated with, this desire to create and produce and be, productive in society. So that's why I don't like how haphazard people are and just like throwing everyone on 5-alpha reductase inhibitors.
Yeah, I'm definitely the same way. And, Dr. Kyle Gillette and I got into that quite a bit, and we talked about, post-finasteride syndrome, and it was quite a discussion. But yeah, a lot of people, I think are waking up to this. This is something that I seen, more and more, in mainstream media, even, and certainly on social media, that people are waking up to the fact that, DHT does play a role past puberty. And, certainly, I think you can even get into a situation where someone can have, high testosterone, total and free, and low DHT, and still sort of suffer from like low androgen, sensitivity, or sort of just like low androgen overall, because they're not getting the DHT that's, giving them the cognitive function, the muscle building, the confidence, all that sort of comes along, with DHT. And so, when you are, treating someone for testosterone, is that a test that you commonly order is DHT?
Yeah, now more and more I'm looking at DHT and specifically the DHT to testosterone ratio. The way you think about it is that the androgen receptor is going to be partially filled by testosterone, partially filled by DHT. And you can even throw in DHEA into that conversation. I think Dr. Kyle Gillette has a very nice video where he's talking about the overall androgen quotient, which would be DHEA, testosterone, and DHT. There's a bunch of different androgens too that we could throw in there, but then we're just getting into the weeds of things. But DHT more and more, I'm looking into that. I'm looking into the ratio of DHT to testosterone, which people, if you look at studies, 50 years ago, we're looking at a ratio of 8-to-1 to 6-to-1 of testosterone to DHT total to DHT total. And nowadays you're finding people that have, 10-to-1, 12-to-1 ratio. The clinical question that would be interesting to examine moving forward is this ratio part of the androgen problem that people are experiencing, part of the low libido, low sperm function, low fertility crisis that we find ourselves in?
Yeah, no, very, very interesting. And I just want to ask you too, one more question on that, similar on that topic. So I also got into with Kyle Gillette and then also Ashley Winter too about the CAG repeats.
Yes.
And so they're indicating now, from my understanding, it's the more CAG repeats, I think the less sensitive it is. Is that correct? Yeah.
That sounds right, yes.
The less CAG repeats, the more sensitive your androgen receptors would be. So is that a test that you think people, like say if someone has, normal testosterone, normal DHT, and they're still, they still sort of have these feelings of low T, so to speak. Is that maybe a potential test that you would order for someone like that? I know it's a very difficult test to order.
It's difficult to find.
It's like $500 or $600, and it's like the turnaround time I think is a couple months or something.
Yeah,
like it's not,
exactly. Yeah. It would be great if like a 23andMe or one of these genetic companies just included it in their package. They don't, unfortunately. And I think Dr. Gillette had it on his website, but I don't think he does anymore because I had set some people.
He does. Yeah, I had to message James. I think they gave me the link to the company that they ordered it from, but they didn't really want to be associated with the company because it was taking them too long to get the test back to people. I think that's my understanding from the conversation I had with them. I'm
going to have to get that link from you because there's a lot of people that want to figure that out. It'd be an interesting test if somebody comes into you, you've put them on TRT, let's say, they're still not experiencing good results. And then it could tell you as a clinician, like, hey, this person, maybe they need a little bit more testosterone onto their dosages so that they can get to a higher level to get that androgen signaling. And it'd be interesting if somebody has like a partial androgen insensitivity syndrome where their androgen receptors are so poor that they're almost having, ambiguous genitalia. They're not developing the normal, beard development, hair development, physical development. But you could also tell that on physical exam. So yeah. It's hard to justify a $500 test when most of these things can be figured out by exam and talking to the person. Because when it comes to deciding whether or not to put somebody on TRT, there are people walking around with a testosterone of 300 that feel and perform way better than people that have a testosterone of 600, 700. And it's really a function of androgen receptor, like you mentioned, the DHT ratio, the estrogen to testosterone ratio. And if you get into the weeds, there's like androgen receptor sequestration in the mitochondria and all these things that people are only starting to find out about. And that's why you have to look at the clinical situation along with the lab test. Everybody's just so gun trigger happy with the lab test, when really, like as a clinician, you need to kind of look at the person and see what's actually going on under the hood.
Yeah, I agree. And so some other things that might be going on under the hood and some other, ancillaries that people could use for testosterone. So one thing you've talked about quite a bit recently is Pregnenolone, which is known as the master hormone. And so, I think we produce about 10 to 15 milligrams of that per day, something like that. If someone is on TRT, in terms of ancillaries, we're talking about Pregnenolone now. Is that something that you think that people should be on, if they're taking testosterone?
You should definitely check it. Pregnenolone, DHEA, all these things, and look at what the levels are and then replace them along with the TRT if you are in need of replacement. Especially a lot of these guys that are, androgenic, they're on TRT, they're very goal-oriented going forward in their life. They get into this pregnenolone steal syndrome where they're making so much cortisol from the pregnenolone. Because it goes cholesterol, pregnenolone, and then pregnenolone can go down the HCG axis, the hypothalamic pituitary gonadal axis, make testosterone, estrogen, all these things. or it can go down the cortisol pathway and make cortisol and your stress hormones. So whether somebody's on TRT or not, you could look at their pregnenolone and kind of tell if they're shunting that away from making androgens and they're making more stress hormones with it. So they call that pregnenolone steal syndrome. So that's why it's an interesting lab test to check and then replace it if people are low. There's a whole community of people online, these so-called Peters, that follow this guy named Ray Pete, and they're all about taking boatloads of pregnenolone as an anti-stress molecule. That hasn't, I think, been found in the clinical literature. It's more of an anecdotal thing that people are finding.
Like how much are they taking?
Taking 50 to 100 milligrams a day, sometimes
50
more.
to 100?
Yeah.
Holy shit, that's a lot.
Yeah. I mean,
it seems like quite a bit anyway.
I mean, most guys will get gyno if they take 100 milligrams a day of pregnenolone, because they're just going to aromatize the heck out of it, and they're going to end up with, DHEA, and then it's not a good combination. Like, I think Nootropics Depot sells a 5 milligram sublingual pregnenolone tab. That's mild and nice. Let's call it that.
Seems like it's efficient. If you're only producing 10 to 15, you may only need then a few more milligrams to get you where you need to be. So yeah, even if you do have high T or normal high T, normal high DHT, it is good still to look at the other hormones like pregnenolone, DHEA. So you will get benefit by maximizing those other hormones. And you kind of just explain that too, like you said, that Kyle has that video where all those things kind of hit the receptor. So you don't just want testosterone, you don't just want DHT, you don't just want DHEA. You kind of want a balance of all of them to round it out and make sure that the receptor is sort of filled out, as so to speak. And then in terms of LH and FSH, so some people are really gung ho on using HCG during TRT. Some people, don't want to do it. It is, somewhat tedious. Like most people generally use about, from the most of the data I've seen is like 250 IUs, maybe a little bit more, like 3 times a week. And it is, injected, which again, some people really don't like doing and can be expensive. And it seems to, the stock that we have in Canada anyway seems to expire quickly. But I don't think it expires as quickly as it says on the bottle. But in terms of using something like HCG, is this something that you would just use and evaluate the person clinically with, or is this something that you think that no matter what, is, and again, we're talking about someone who doesn't want to maintain fertility? Because if they want to maintain fertility, then you have to be on HCG. But say if you just don't care about maintaining fertility, do you think there's still benefits in using HCG?
There are LH receptors in the brain, which becomes an interesting situation, because if you're on TRT long enough, your LH will approach 0 or actually be 0. So the question is there downsides to not having any LH stimulation throughout your body at all? And I lean towards yes, it's probably a better idea to have some LH stimulation through HCG. At least to kind of offset that, because there might be some cognitive effects. There also is possibly adrenal effects of LH that might be important, might not be. I don't think the jury's out on that yet. But I personally, if someone has the ability to do it and is more with it as a patient, that'd be an interesting thing to add on. Of course, it comes back to the patient. It's a risk-benefit discussion, and I always will tell the patient, this is what I think. This is why it's a good idea to have HCG. But if you don't want to be, or you just want the testosterone, you don't care, it's also the patient discussion to have. And I think as clinicians, it's better just to kind of present the patient with the information, educate the patient. And at the end of the day, they got to make the decision.
Yeah, I agree. Like with everything you said, I think that there's, evidence enough to suggest that people, can take it and can benefit from it. But I also agree that like, if someone finds it super expensive, they're already, feeling pretty good on testosterone alone, and they feel like they don't really need anything extra, and I would, say, why don't you stay off of it? But, like you said, it's kind of odd sometimes to just like cut out a hormone completely, because it could be doing, something else. Like we just talked about the DHT, people thought that, that's only important, say, during development. We obviously strongly disagree with that.
Mm-hmm.
Some people may say, we need LH for fertility reasons, but, again, we may find out, and some people may, experience just, greater benefits when using, HCG when they're combining it with testosterone. So, Interesting. What about the like doing it without a prescription? So Tongkat Ali, I think, is like, the strongest one out there
Right.
in terms of, raising testosterone to some degree naturally with an over-the-counter supplement. If someone is already on testosterone, what's taking something like Tongkat Ali assist with LH production and potentially, maintain it slightly. I'm certainly not saying it's like comparable to HCG or anything like that, but it's something that some people may benefit from.
It seems to me that if you're on exogenous testosterone, the amount of LH suppression that you're getting through estrogen binding to your hypothalamus is so strong that there's not much that's going to overcome that. To the point that even if you're on TRT, if you take enclomiphene or clomiphene, you don't get much of a LH or FSH response out of those. And those are like pure SERMs that literally block estrogen in your hypothalamus. Because it seems that the LH and FSH production, the width of the hormonal response is dictated by estrogen, and the peak is by DHT. Actually, there's like a bimodal response where both DHT and estrogen suppress hypothalamic LH and FSH production. So I don't think Tongkat Ali is going to overcome the suppression that the estrogen will give you. Perhaps if somebody was doing like a daily injection of TRT, which some people that are like bio-optimizers will get into that, perhaps then a serum like enclomiphene might work, but I doubt that we'll see Tongkat. Clinically, I haven't tried that, so I'm curious to see if somebody who's done that clinically has results there.
Okay. And then regarding estrogen, natural estrogen blockers, like it doesn't seem to be anything out there that's close to a Arimidex. Like a Arimidex is so powerful, it's crazy. I wish it came in Canada anyways. It only comes in 1 milligram, and you can split it into 0.5. But again, even 0.5 is like a pretty like whopping dose. Like a lot of people only need like, maybe 0.1 or 0.2. But the only things that I've seen that have, any kind of research on, and there's one called Chrysin out there, but again, I don't really see, anything clinically in the data that, really points to me as like, yes, this is like a highly evidence-based compound that's, certainly going to reduce your estrogen levels. But, guys are always asking me, is there anything natural like Arimidex? And my answer always like, not that I've seen, whatsoever. What are your thoughts on that?
I mean, the thing about playing with estrogen, it's a very dangerous game, let's say, because whether that's using natural so-called compounds or pharmaceuticals, and that most people do not have the commitment to getting labs regularly and trying these things out. And then they end up with an estrogen of 5, their joints hurt, they can't have an erection anymore, they're miserable, they're suicidal. And then you're like, oh, because you're taking Arimidex 1 milligram a day, when you should not even be approaching that dose. So when it comes to these kind of things, the thing is test, don't guess. Like if you're going to play around with your androgens or your estrogen or whatever it is, you need to be very diligent in buying labs. So if you're signing up for this optimization game, you're signing up for a lot of lab draws and figuring out what's going on until you find a protocol that works and you have stability. And that's the bottom line there.
And I think too, it's really important though, like guys always think lower estrogen, like, lower estrogen as much as you can. So tell guys why that's so bad.
Yeah, so estrogen is not the enemy of testosterone that people make it out to be. There are some effects on the man that are not desirable from estrogen, whether that's gynecomastia. Too high of estrogen can make you a little bit aggressive and not more moody, let's say. But estrogen is very, very important for sexual function, for bone health, for heart health, for brain health. Maintaining all these pathways it's very important. The amount of estrogen you need will vary based on how much testosterone you have and finding the optimal ratio. And the confounding factor that most guys go through is that their amount of adiposity is ruining their testosterone to estrogen ratio. Because there's this very interesting, they call it the obesity inflammatory shunt from testosterone to estrogen, where if you're very obese, you have a bunch of visceral fat and a bunch of inflammation that converts a lot of your testosterone to estrogen. So the ratios get thrown off, where you'll have somebody with an estrogen of 60 and testosterone of 200, 300. While if somebody's on TRT, their testosterone's over 1,000, it makes sense to have a higher estrogen amount. And then that's where you have to have that clinical discussion of what the right ratio is for you. There's going to be a different ratio also for different symptomologies that you want. Like if for sex, there's going to be a ratio that's ideal. For productivity and sport, there's going to be a ratio that's ideal. So it's very hard to pin this down. And that's why unfortunately, the mainstream endocrine world doesn't let you go into this kind of optimization.
Yeah, and which is exactly why, brings us back to the start of the show, why we need, sort of a separate care
Right.
of, primary care physicians who are, just spending all their time looking at this and also spending a lot of time researching it because, this game is changing very, very quickly in this space. And, you need to be reading essentially, like I'm sure you do. I know you do because I see your tweets. Like, you read every single day. I'm constantly reading, like, something comes up and, we live in an age now where, you can look things up really quickly. Right. And so, it's easy to get a lot of information. Staying on the topic of hormones, but, switching gears just a little bit. So, C made some pretty funny tweets recently about, how if guys use too much cologne, it kind of damps down their pheromones. And so we're talking about hormones now. Of course, guys, work out, to get healthy, but we know that all guys want to work out also too to kind of attract the ladies. So they're doing that. But what about this blocking of their pheromones, and explain that, and why is it arousing, say, for, females to have this, particular smell of certain pheromones?
So pheromones are hormonal byproducts that are released in your sweat. They're released in your urine and other tissues. A lot of the data for pheromones comes from animals, because in the animal world, pheromones are super important. Like an animal will pee on a tree to mark their territory, so another wolf won't come near that place. Less so in humans, but we still have this pheromonal signaling. There's an organ in the nose of animals that senses pheromones, and there's a debate whether or not humans even have this organ that still exists. It seems, though, based on data, there is a pheromonal response between male to male, female to female, and male to female interactions, to the point where females will synchronize on their menstrual cycles if they hang out with each other long enough. Now, there's a bunch of these different pheromones, and to bring back some of the earlier discussions, 5-alpha reductase is actually important in producing some of these pheromones. So these pheromones, there's androsterone, androstenone, to name a few. They signal to other men to compete with other men, and they can cause like conflict between guys. They signal to other ladies around you, if you're a healthy, robust young man, or older man that's still healthy and robust, that you're fertile, that you're still producing enough testosterone. Because if you have enough testosterone, some of that will be shuttled down through 5-alpha reductase and other different hormones into pheromones that are released in your sweat. The problem is we're all suppressing our sweat glands with deodorant and cologne. Now, if you think back to like middle school, where you could smell in the air the fertility and the hormones are pumping in the air. People aren't introduced to deodorant yet. And you could tell how that would stimulate somebody to be more hypersexual, more seeking of the other sex. So it becomes an interesting world where most people now are either suppressing their pheromones through deodorant, cologne, all these different things, perfumes, and then not producing sufficient pheromones because they're either, as a man, low T, or as a female, they're on oral contraceptives. And that's blocking LH, FSH, and it's blocking downstream production of some of these compounds. So the data is not robust on this, but it'll be interesting to see how that kind of interaction happens.
So if you're, a guy and you want to make sure that you're maximizing your pheromones, like how would you exactly do that? Obviously, you're not going to tell us to not wear any deodorant, but how would you do it? And how do you do it, Abood?
Yes, so you want to be to the top of the reference range when it comes to your androgens, of course. That's gonna allow you to produce the most. I personally, I don't use aluminum-based deodorants. It seems that those are eventually going to be found to be not good for human health, although the jury's still out.
And so would that mean, though, that like aluminum ones would potentially block the pheromones, but the natural ones wouldn't?
Theoretically.
Okay.
Now we're in a space of theory more than actual data. I've been doing an experiment lately where I'm wearing less and less of the stronger deodorants, very like minimal ones, using more like a natural olive oil based soap to see if that changes the pheromones. We'll report back.
I like it.
Experiment is completed. It seems to be having an effect, but we'll see. And also I think for men, you'll be able, if you tune in, you'll be able to tell when ladies around you are ovulating based on their pheromonal signatures.
That is wild. But it makes sense, especially when you go back to like the animal stuff and you talk about that. One more question on this too. Like, there's some clones out there. Like, I know there's one Raw Chemistry. There's a, they're one company that produces them. So there's companies that literally are now producing sort of like pheromone colognes. Like, any thoughts on those? Are those something that guys should be wearing, not wearing, or is it more like your natural pheromones? That's the real response.
What we seem to know is that if you or your partner love the smell, the natural smell of each other, that is associated with good potential for like immunological compatibility when it comes to forming offspring. So the question is, would this be kind of messing up with that? And you're playing a game where you're attracting the wrong mate or you're finding the wrong partner. And then what happens if you stop wearing that pheromone? Does the person become less interested in you as a partner? So you're playing a dangerous game there. It seems that there are pheromones from the hormonal pathways, and there's other pheromones that are being produced that are non-androgenic, non-estrogenic, that also signal different things to a partner. So it's hard to say if putting on like androstenedione is going to change the way people will behave around you. It'd be interesting to see if you put it on, wore it to the gym, if you get into more conflict, or other guys would want to stay away from you, or you're marking your territory or something like that.
Yeah, that's interesting. You don't necessarily have to use it, out on your first date. You can kind of just, explore it in other social settings and see what happens. And, maybe that'll give you a little bit of a prediction.
Because they're finding that, like if a young girl has a stepfather in the house, she will enter puberty earlier than if it was her regular father there. Because his pheromones are foreign to her, while the father's pheromones would be endogenous, I guess, because she shares some of those genes. So having a stepfather in the house is actually associated with earlier puberty for ladies, which is, crazy.
That is wild. Well, it seems like, an area that needs to be explored, considering, we're finding all these things. So I know I only have you there for another 5 minutes or so, but one thing I want to ask you about is you seem to have a really great bedtime routine, and one of the things that I really appreciate that you put in your bedtime routine is that you say you forgive all haters, and, you have your little prayer before you go to bed. And and no matter what literature you look at, like any old scriptures and stuff, it always seems like, going to bed angry is a bad idea. Going to bed angry is not good. And so I love that you included that there. But if you don't mind, if it's not too personal, I don't think it is, because you kind of went through it on Twitter, just kind of bring us through your bedtime routine. And I know that you may say that, well, it really starts at, 6 a.m. or so, or by watching the sunrise in the morning. But a lot of people are struggling with sleep these days, and you seem to have a really good routine. So, just kind of share your thoughts on that.
Yeah, I mean, like you said, sleep starts the moment you wake up, because it's on a 24-hour cycle, and you can't decouple day and night. Day and night are coupled factors that dictate human biology. So when it comes to sleep, I think, and thanks to the work of someone like Dr. Andrew Huberman, we've gotten people to realize the importance of morning sunlight for sleep. And for me, the way I teach people about this is the ratio of the brightness of the first hour of your day and the last hour of your day. The problem in most modern homes, during the daytime, the windows are barely open. You have some lights, but at night, the lights are blaring, and it actually looks brighter at 9 p.m. than it does at 9 a.m. That's a very confusing thing when it comes to calibrating the circadian clock. So the goal is, I think, to make the days brighter, especially the morning part of the day very bright, and then dim the lights as you get closer to bedtime. Some people put on those red lights at night. It looks like kind of a whorehouse, so it's not ideal, I think, for most people. But dimming the lights is important, and finding lights that have less blue light in them, and then lower in the field. So the sun, you want high above your visual plane, especially around noon. At nighttime, you don't want lights above you signaling that it's daytime. You want lights that are lower in the field, lamps, these kind of things. They're also less stimulating. If you go into a house that has lamps, it's kind of a low-key setting, kind of helps you get into this parasympathetic state. The other thing is that most people now, they go work, gym, very active on social media, and then they want to sleep right away. You can't do that. The body needs to go into a parasympathetic state, and you slowly kind of unwind. And I think that's where some of the things you mentioned come in. We can put in all the science, we can do all these things, but if you're spiritually hurting, spiritually in a bad place, you're not going to get that restorative sleep. You're not going to get into that very good state that you need before bedtime, during bedtime. So that's why it's important to kind of cleanse the heart, as it were, let things go. It's not scientific necessarily, but you get into a state where you're at peace with yourself, you're at peace with the world. You, if you're a religious person, you say your prayer. If you're not a religious person, whether it's meditation or something that, allows you to kind of get into that very calm parasympathetic state. Because in order to get deep sleep, you need that parasympathetic state. And most people are trying to take supplements to get there, when the reality is breathing, state of mind, activity levels are way more potent in manipulating the parasympathetic versus sympathetic nervous system than taking L-theanine or something like that.
Okay.
Not that those are good. Those are great, but still.
Yeah, no, that's really important. And I'm happy that you said that, because, a lot of people aren't really too aware of that. Like, you need to calm down your sympathetic nervous system and get into a parasympathetic state. And like you said too, like, the literature shows that, like, if you do prayer, if you do meditation, if you do some deep breathing, if you do some things that have, been shown through, decades, even centuries in some degree to, like, actually calm you down, then you're likely more to get into that, deep state of sleep. And that's another thing too, like, when you're on, stimulants and things like that, it's very difficult to get that restorative deep sleep that we're talking about, because, you have that sympathetic, state that's kind of just like driving you up. So I know we only got about a minute left there. Is there anything else that you wanted to share before we say goodbye to everyone?
Yeah, I think, all the things that we discussed are interesting. And I think that people will now have to realize that they are their own chaperone of their health. They can depend on their doctor. They can work with their doctor. They can do all those things, but there's information out there. There's, validated sources, and everyone has to be, kind of their own personal doctor, as it were. I'm not saying that you're going to prescribe yourself things, but you have to be out there. You have to be aware of what's going on. You have to make decisions for yourself. Because at the end of the day, a clinician can tell you, do this, do that, but then it's on you at the end of the day. And I think that people are realizing that the onus of healthcare isn't in the clinic, in the hospital. It's in the home. It's on the telephone. It's on the social media apps. And people have to take that kind of responsibility for themselves.
Yeah, I think so too. And I think hopefully, people will wake up to that particular message. But for sure, even as a clinician, I'm sure you agree that, when someone is taking care of themselves, when they're, aware of what's going on, when they know exactly what's going into their body, it's much, much easier to treat that person, but when someone comes in and, they don't even know the names of the medications that they're on, and, they're not really aware of, what they're eating, they don't have, a good lifestyle, it's hard to, manage that particular person. Like, we're just going to make, very, very, very small steps. But, when you're, taking care of someone who's diligently looking after their health, who's bringing in blood pressure readings, showing you, what's going on, it's, much, much easier to take care of them. So,
right, 100%.
I think that, hopefully that message gets, out there, and hopefully people take that more seriously in the future. But brother, thank you so much again for coming on. We got through so many good questions today. We provided people so much good information. So just tell people where they can find you on Twitter, on Instagram, and anything else that you're doing. Yeah,
Twitter is ABUDBAKRI. I think Instagram, same thing, but underscore between the first and last name. But if you search the name, it'll come up. And my pleasure to be on your show. It's a really, really good discussions that we're having here, and hopefully people will benefit from that.
Dr. Abud-Kari, everyone, thank you so much again. And thank you everyone for listening. And as always, I'll be back again soon.